Well, good afternoon and good morning. Thanks for attending our webinar. And the title is Back to the Basics, Preventing Administration of Neuromuscular Blocking Agents in Unventilated Patients. And this is something that we've wanted to do for a few months now. We had an incident many of you are aware of at the very end of last year. We became aware of it had actually happened prior to that at a very prestigious hospital in the southern United States, where a paralyzing agent was accidentally given to an elderly woman in a radiology department. And we're not going to review that case. We did do that in our January 16th issue, and we fully described the case and also gave a number of recommendations and also included some information from an earlier article we did in 2006, and that is referenced in that material from January 16th issue. I'm sorry, the issue from 2016 was January 16th. Our own issue was also January 16th this year. I'm sorry, I said January, I meant June 16th, 2016 was the original article that we published on neuromuscular blocker errors, and we went over the case in January this year. This is certainly not a new problem, medication errors with neuromuscular blockers. It was one of our original listings in our first list of high alert drugs, and it even showed up in an article we did in the 1980s called Today's Poisons, when we did a survey, and we asked hospitals from around the country to let us know what those drugs and drug categories were that were harming patients the most, or even causing fatal events. And my colleague Judy Smetzer, who's a nurse, is with us today, and Judy's going to be speaking in just a minute. Judy started a fellowship here back in 1997, and I think one of the first tasks at that time, I happened to be chairing Medication Errors Committee for the United States Pharmacopoeia at the time. And one of the major issues that we had to go over was the neuromuscular blockers. We had had a number of cases up until then that we had written about as early as, well, even before 1996, before our newsletter began publication. And many of them were name mix-ups. For example, right around that time, we were seeing quite a few mix-ups between Norcuron, which is the paralyzing agent brand name, and Narcan, naloxone. So Narcan, Norcuron was getting mixed up. We also had other incidents where people were intending to give influenza vaccine in an emergency room. We had a number of these cases where they looked for the influenza vaccine vial and picked up a paralyzing agent vial. And we had a number of patients in different locations in this country and outside the United States that had a mix-up with that vaccine or another vaccine. So that was another issue that we had. We also had issues with unlabeled syringes. I remember one that we had was someone thought they left a saline syringe unlabeled in an emergency room. And someone had actually drawn up a paralyzing agent and didn't put a label on it. And that was another issue. And then there were vial mix-ups. we had all kinds of problems. In those days, we didn't have the automated dispensing cabinets, but that was a factor in this most recent case that we wrote about back in January. But at any rate, the USP committee felt that it was time to do something about it. And I'm happy to say it did result in some more awareness of the problem and also some changes. And we'll go into them, label changes that is, and we'll go into them in a few minutes. So for now, I just want to let you know we do have a handout. It's on, maybe you can see it on the right-hand side of your screen. One of those tabs says handouts, and you should be able to see PDF, and that is the PDF of the slides that we will be using this afternoon and this morning. So, Judy, why don't you take it away, and I'll catch up with you in a little bit. Thank you.
Okay. Thank you, Mike. So today we'll be covering two objectives. I'll begin by describing the underlying causes of events associated with administering a neuromuscular blocker to an unventilated patient. Most of these causative factors are based on analysis of events that have been reported to the ISMP National Medication Errors Reporting Program. And then Mike will be examining the best practices associated with neuromuscular blocking agents, along with presenting some of the data around neuromuscular blockers that we've been able to collect during our 2018 medication safety self-assessment for high alert medications and in surveys on our targeted medication safety best practices, of which one is associated with neuromuscular blockers. So neuromuscular blockers are considered high alert medications because of their well-documented history of causing catastrophic injuries and death when used in air. Because that neuromuscular blocker paralyzes the respiratory muscles, patients have died or they've sustained serious injuries if the paralysis was not witnessed by a practitioner who could intervene or a family member that could call for help. So even if the patient survives, unfortunately, the experience can be pretty horrific because they're fully conscious. Even when they receive the neuromuscular blocker, they just can't breathe, so they're suffocating but fully aware of that. So we've received about well more than 100 error reports involving neuromuscular blockers. And we know that this is just the tip of the iceberg in regards to what's happening out in the country. Many of these events have happened outside the perioperative setting where we would expect neuromuscular blockers to be used. In areas outside that tend to use neuromuscular blockers like the ED, critical care units, labor and delivery units, radiology departments, but we also see these events in medication, in med-surg type units or even in newborn nurseries. In more than half of these events that are reported to ISMP, neuromuscular blocker is not the intended medication. It's been inadvertently given to a patient when practitioners thought that they were administering a different medication. So it's different than the intended medication, and it's unfortunately been administered to a patient that is not mechanically ventilated because the practitioner often had no knowledge that they were actually administering a neuromuscular blocker. And then more than a quarter of these events have resulted in patient harm, mostly death or anoxic brain injury because of the catastrophic nature of not recognizing that an error happened and the patient's inability to breathe. So errors with neuromuscular blockers can be attributed to both active and latent failures. I'm sure you've all seen the Swiss cheese model of medication errors or medical errors, in which the arrows represent the active failures and the Swiss cheese and the holes in them represent the latent failures. So when an error happens with a neuromuscular blocking agent, it can be due to active failures, which are the specific actions of humans that contribute to the event, things like human error and behavioral choices that they may make that may set them up to make a human error. And then also the latent failures are the underlying organizational features and equipment technology designs that set people up to make mistakes. That can be everything from the culture or the organizational influences in an organization to preconditions and the way that systems are designed to technology or equipment design failures or limitations in some of the technology that we have that I think Mike will talk about a little bit later. Today we're going to be mostly focusing on the latent failures or those system-based causes of neuromuscular blocking events that wind up being given to a patient that is unventilated, unless those active failures are associated with things that would be directly related to neuromuscular blocking agents, such as a knowledge deficit where a nurse doesn't know much about the drug or that it causes respiratory paralysis. So the first contributing factor that I'd like to mention is probably the most common basic cause that we see with neuromuscular blocking errors, and that has to do with unsafe storage of these drugs. So the neuromuscular blockers involved in errors have been available in units where they were not needed, and they were often unexpectedly found in a storage location, or they're found in areas where patients cannot easily be ventilated or monitored by practitioners with appropriate competencies. And I'd like to just give you some examples as we're going through these causative factors, and these are real examples of errors that have been reported through the ISMP medication errors reporting program. So for example, related to unsafe storage and not expecting to find a neuromuscular blocker in the unit, we had one case reported to us where atracurium was administered instead of a hepatitis B vaccine to several infants who developed respiratory distress. One infant sustained permanent injury and another died, unfortunately. The neuromuscular blockers had never been available in the nursery, and an anesthesiologist from a nearby OR had placed the atracurium vial in the nursery refrigerator near a Lookalike vaccine vials just temporarily. So it was never expected to find that type of drug. So the nurse reached into the refrigerator, grabbed the hepatitis B, what she thought was hepatitis B, and administered it. But even if neuromuscular blockers are appropriately stocked in a unit where they might be needed, mix-ups with other medications have frequently occurred when they have not been sequestered or differentiated from other medications in refrigerators and ADCs and other storage locations. And again, I'd like to give you an example from our database. So in a pediatric ICU, a respiratory therapist obtained what he thought was sterile water in a vial to prepare a nebulizer treatment. As he was piercing the stopper, he noticed that he had accidentally grabbed the vial of atracurium that someone else must have inadvertently returned to a respiratory box in the refrigerator. So again, it might have been appropriate in the intensive care unit, but it wasn't sequestered or stored properly, and so it wound up in a respiratory therapy box that caused a problem. Many of these types of errors are also due in part because of lookalike labeling and packaging. For example, an ED nurse administered pancuronium instead of influenza vaccine to several patients. Mike just mentioned the problems that go back many, many years and are still happening. But the vials are the same size and the labels are quite similar, and the lookalike vials had been stored next to each other in the refrigerator. And the patients experienced respiratory depression, but in this particular case, there were no permanent injuries. But as Mike mentioned, other infants and children have not been so lucky. One of several infants who received a measles vaccine reconstituted with the pancuronium instead of sodium chloride died several years ago. And as Mike alluded to, 15 infants died in Syria due to a neuromuscular blocker that was used to reconstitute the measles vaccine instead of sodium chloride vials that look very similar. So lookalike labeling has been at the root of many neuromuscular blocking errors. On the screen, I've also given you a couple examples of lookalike vials that have been particularly problematic and caused confusion. We have vecuronium flumazenil that look very similar, especially after the caps are removed, and they're both commonly stored in procedural areas. And then the other example that I gave you is vecuronium and vancomycin. You can see once the caps are removed from those vials, the labels look very similar, and both of these are lyophilized powders that require reconstitution. So expecting to see that it's a lyophilized powder, you might not realize that you have the wrong vial in hand. So practitioners have also confused neuromuscular blocker drug names with other drugs because of lookalike drug name problems. Mike alluded to one in his introduction. Narcan and Norcuron have frequently shown up in our database as being repeatedly confused. In one case, a nurse transcribed a verbal order for Narcan correctly, but the pharmacist misread the order as Norcuron, And he thought, and then when he dispensed that, the nurse thought Norcuron was the generic name for Narcan and administered the drug. In another case, a physician prescribed Narcan, but an ICU did not recognize this drug on the automated dispensing cabinet screen because it was listed by its generic name. And so she intended to ask a coworker for Narcan's generic name, but she mistakenly asked for the generic name of Norcuron. When she was told that it was vecuronium, she removed vecuronium from the ADC and administered it. And that patient wound up on a ventilator and fortunately recovered. But there's a whole host of lookalike drug names that have led to accidental administration of a neuromuscular blocking agent. Narcan has been mixed up with Nimbex. Versed has been mixed up with vecuronium. And not just in the highly publicized case, but before that and since then also. Another common contributing factor to inadvertent administration of neuromuscular blocking agents to an unventilated patient is order entry systems and ADCs that allow drug name searches using just 1, 2, 3 letters. I have a couple examples on the screen. But we have so many examples in our error database of problems with selecting the wrong drug in a drop-down menu that we can link to the capability of entering just a few letters before choices populate that search field. And then all those choices are usually drugs that look very similar and the wrong ones eventually chosen. So the example that I give you is CIS that was entered during order entry. In this case, it was pharmacy order entry of an infusion of cisplatin that was intended, and a mnemonic CIS was used, and it completed the drug name field with cisacurium, generating a label for the neuromuscular blocker, which was then prepared and dispensed to the patient. But again, we have many examples of these drug name searches in various order entry systems that are causing problems. The one that Mike alluded to with the case that happened about a year ago had to do with VE, and which was mistaken as vecuronium instead of Versed. And in that case, it only required 2 letters before drug names appeared in the search field and the wrong drug name was selected and administered to that patient.
Judy,
so,
let me just interrupt for a second. And we've actually had 2 reports come to us where VE was typed in and the wrong drug was initially chosen instead of Versed vecuronium. And we have had 2 of those happen. And one of them was actually not a choice off the screen, but it was a syringe mix-up between the 2. And actually, neither one of them reached the patient, fortunately. But obviously, those drugs are still out there. Although Versed, that brand name is not used anymore, people are familiar with it instead of midazolam, so they use that. So, you know, there's just no telling where else this might happen. So I just wanted to mention that.
Yeah, we should mention that it's not an isolated case, that we have received other events where Versed has been mistaken as vecuronium, and also specific events, like Mike says, with VE being entered into a search field and with the intent of finding Versed, and vecuronium was selected. Fortunately, the very last case that we had reported, the error was caught before reaching the patient. We also know that unlabeled syringes have led to mix-ups with neuromuscular blockers. Mike mentioned an example where in the ED, an unlabeled syringe of vecuronium that was not used for a patient who was undergoing a rapid sequence intubation was picked up afterwards and placed in a supply of unlabeled syringes of normal saline that were often used for flushing, and then picked up a little while later and used to flush the IV line of a 3-year-old. So you can imagine how scared that 3-year-old was when they were fully awake and couldn't breathe. We also have a lot of examples in our database of syringe swaps between various neuromuscular blockers and other drugs that are being used in the perioperative areas in the OR by anesthesia when those syringes aren't labeled. So things like mix-ups between midazolam and rocuronium or fentanyl and succinylcholine are the ones that we tend to hear about most frequently. And then we even have some label mix-ups where the syringes are labeled, but the labeling process is such that it causes a risk of error. And one of the more recent errors that we had reported to us had to do with batches of pharmacy-prepared succinylcholine and ephedrine syringes where they accidentally switched the labels on those. So they were dispensed, and fortunately anesthesia, when they gave what they thought was ephedrine and it was reacting just like a neuromuscular blocker, was able to identify the problem. There's also a problem with, and I should say it's a very common underlying cause of neuromuscular blockers, is that there tends to be an unclear or absent warning on the vial itself or on the storage location. And the fact that the drug causes respiratory paralysis and requires the patient to be mechanically ventilated is often overlooked, not seen, or misunderstood. So the manufacturer is required to put a warning on the cap of neuromuscular blocking agents, or the ferrule if the cap is clear, that says warning paralyzing agent. And I showed you a little glimpse of what that might look like on the ferrule of a clear cap of a neuromuscular blocking agent. But based on error reports that we get, that warning appears to be overlooked frequently or misunderstood. Nurses in particular have not understood its meaning, and when we have followed up with them, they tend to think that they understand paralyzing agent, but they're thinking limb paralysis and they're not thinking it through, that it's respiratory paralysis and that the patient needs to be ventilated. So we're not so sure that paralyzing agent is getting the message across. So the warning doesn't necessarily capture attention or help the user understand what is going to happen to the patient as far as respiratory paralysis, and they don't understand the action that is needed, that the patient needs to be ventilated, mechanically ventilated if they're going to use that drug. So we're finding that the warning, although we fully supported the warning on the vials, is too easily overlooked and misunderstood to be considered an effective warning system. Now, we've seen that because this warning system isn't effective, there's been auxiliary warnings put on vials and labels, but unfortunately, if the language isn't such that it's well understood what that warning means, we've had a number of errors reported where the end user just doesn't understand what is meant by the auxiliary warning. One event comes to mind in particular that happened several years ago, and it was a highly publicized event in an emergency department where the intended drug was phosphenotoin, but the drug dispensed was a neuromuscular blocking agent. And it actually had a sticker on it that said neuromuscular agent. And that was misunderstood by the end user, by the nurse, to mean that the drug was within a class of drugs to control seizures because of the neuro part of it. So there's just not a lot of understanding what neuromuscular agent means or what paralyzing agent means, or thinking through that it causes respiratory paralysis and the patient needs to be ventilated. We also know that a lot of times these warnings aren't on the storage locations, on the pockets or the ADC screens, so that even if I'm not intending to remove a neuromuscular blocking agent, If I'm removing it by accident, there is no warning to tell me that this is a paralyzing agent, that this is a respiratory paralyzing agent. So we find that there's unclear or absent warnings even on those storage locations or on those ADC screens. Now, occasionally, another problem that we've seen has to do with neuromuscular blocker administration after extubation. It's usually pretty close to extubation, but the patient's no longer being mechanically ventilated. So there's usually two reasons for that. Either a continuing order for a neuromuscular blocker after the patient's been extubated, although I have to tell you that ever since the Joint Commission disallows continue the same meds, we don't see a lot of those types of errors. What we tend to see more is leaving a discontinued neuromuscular blocker infusion hanging at the bedside. Shortly after it was discontinued, that was then mistaken as a different infusion. So, for example, one of the more recent events is an ICU patient that was receiving vecuronium and a potassium chloride infusion, was extubated, and then the bag of vecuronium was discontinued, but it remained in the room, and then was mistaken as a potassium chloride infusion and restarted. So we can have those types of events that are still going on, and we've seen those types of events with other medications such as oxytocin, where the bag's discontinued and just left at the bedside, even if it's temporarily, and then mistaken as a different solution. So there's a couple of other causal factors that I want to mention. They don't come up as often, which is why they're kind of all grouped together. The other ones that I mention happen more frequently. But on an occasion, we'll hear from organizations where it was recognized that a neuromuscular blocker is on board and they want to reverse that, and the reversal agents are locked away, they're inaccessible when needed, whether it's neostigmine or sugamadex, they're unable to gain access to it. That's happened several times. It has been reported to us. On a rare occasion, we've heard about an inadvertent IV push bolus of a neuromuscular blocker after extubation, particularly in the PACU, because of a residual drug left in the tubing from the OR. And this may happen when the nurse goes to give a pain medication IV push and or a flush medication, a flush solution that follows that or precedes it. And if the neuromuscular blocker remains in the tubing, then they might get a bolus of that. So that's been reported a few times. And then we have had some order entry errors that have been reported where the neuromuscular blocker was simply entered into the wrong patient's electronic health record. Most of those are due to knowledge deficits. It's entered into the wrong patient's record and the wrong patient gets it, and that patient hasn't been mechanically ventilated. For example, one of our error reports within the past few years involved a medical resident electronically prescribing vecuronium for the wrong patient with a similar name, but that patient was located on a medical unit. The correct patient was in the ICU and on a ventilator. And the pharmacy and technician did not question the infusion, even though it was going to the medical unit. But the interesting thing is that there was an independent double check carried out by two nurses at the bedside before administration, but neither nurse was aware that the patient required ventilation with that drug. So sometimes it's due to a knowledge deficit that the drug actually reaches the patient. Other times, it might occur, the knowledge deficit might occur in an area where you would expect nurses to understand the impact or the effect of a neuromuscular blocker. And when we look at those types of errors, an example would be where an ED physician gave a verbal order for a trauma patient to receive vecuronium and midazolam, which were to be administered prior to intubation. And that was carried out properly, but then he mistakenly entered the electronic orders for these medications into another patient's record. And then the ED nurse who was assigned to that patient, without recognizing that vacuronium would paralyze the respiratory muscles, went ahead and gave that medication. So again, that knowledge deficit doesn't always happen only in areas where neuromuscular blockers aren't regularly used, but we have a whole host of errors that have been reported, either with the timing of those medications or accidental administration of those medications to patients who aren't on ventilators, that in areas where those drugs are typically used. So I think at this point I'm going to turn it over to Mike to talk about some of the best practices for safeguarding neuromuscular blocking agents that can address some of these types of issues that we see repeatedly.
Thanks, Judy. I do want to tell you that we are taking questions at the end. We should have a few minutes for questions. So on the right-hand side there, you probably see there's an area there where you can pose a question to us, and we'll try to get to those later on. The first thing I wanted to go over was the prescribing area. Really important, especially obviously for areas outside of the perioperative area, that if at all possible, you have a protocol or an order set that's available to help standardize things as much as possible. So here you would obviously spell out the dosing and monitoring that's needed, and the conditions where it would be used. Spell out the sedatives, and the sedative dosing would be another thing that would be important. Obviously, non-patient on a neuromuscular blocker, unless they're unconscious, should you avoid using a sedative. Also, using appropriate drug names and maybe ocular lubricant as well. So all that should be spelled out in a protocol or an order set. The other thing, don't allow orders for neuromuscular blockers with directions to use for agitation, quote unquote, for agitation. And that seems kind of strange. You may wonder why. Well, we've actually had incidents where, for example, a patient was in the ICU and they were using it that way. It was actually ordered that way. And the patient was extubated, taken off the mechanical ventilation, and then transferred to a step-down unit, and the orders were continued. And we've had people, the patient was agitated, and they went back into the intensive care unit, got the neuromuscular blocker, and injected it. So having that happen a couple of times, we do recommend that you not use that type of terminology. And then pharmacy verification of mechanical ventilation in a patient when the patient is outside of the emergency room or the perioperative area where these drugs are commonly used. And Judy kind of alluded to that, where she was talking about, a patient not in one of these areas and somebody accidentally orders a paralyzing agent for that patient. And we have had people off-site. We've had people in different areas of the hospital and not on the unit with the patient, and they have access to another patient's profile on another unit, and the drug was ordered, and it was a disaster. So that we think is important as well. And as many of you know, we did a big project. It was funded by US FDA on high alert drugs. We put a self-assessment together. We ended that last year. And I wanted to show you some of the results from that apply to neuromuscular blockers. One of them that we asked about, one of the items was outside the operating room and the post-anesthesia care unit, neuromuscular blockers are used for maintenance of paralysis in patients on a ventilator are prescribed via a protocol or order set, as I just said. And only about half said they are fully complying with that right now. So at least as of the time this was done, the end of last year, the year before, and then last year, only half were able to say that they were doing this. It's probably a far cry from what it would have been quite a few years ago. So we probably have seen some improvement over time, but this is our baseline for asking this particular question now. So obviously room for improvement. And number two, another one that we asked in relation to the neuromuscular blockers was organizational policies do not allow orders for neuromuscular blocking agents with directions to use as needed for agitation. And believe it or not, there were 66% that said they were fully compliant with that. So we were happy to see that. And then third, if a neuromuscular blocker agent by continuous infusion is ordered for a patient located in a care environment that does not typically support mechanical ventilation, pharmacy staff are required to verify that the patient is or will be supported by mechanical ventilation before the product could be dispensed. And about 30% said no, they weren't doing that at all. But the good news is about 60%, nearly two-thirds, said they were fully compliant with that. So these are three areas we just talked about, and I hope that you'll look into your situation. And when we do the self-assessments, remember it's not just one department that we recommend do it. We recommend that a multidisciplinary committee get together and look over each of the items and keep one another honest and investigate what is actually being done in the organization. And that's how these things should be conducted. So you can actually do the self-assessment even now. It is available on our website. Anybody that hasn't been on our website, you do have to sign in the first time, and then you have a password, and then you can return at any time. You can save your password on the screen, so it's not very difficult. And then you can go to the self-assessment area. It's one of the tabs at the top of the screen, and you will be able to actually take a look at the self-assessment and answer the questions. The only thing is you will not be able to share your data with us or directly be involved with the data that we already collected. But we have been putting together baseline information from the data that was collected. So you should be able to see the basic information that was collected and how hospitals responded. Judy mentioned some issues that we've had with the labeling of the containers. And, after we had that incident earlier in the year that I mentioned, and that resulted, and Judy had mentioned this too, about VE, the two-letter character, intending to be versed, and somebody pulled vecuronium, a nurse pulled vecuronium out of an automated dispensing cabinet. And one of the things that came out of that was pretty obvious that we have been to a lot of hospitals around the country when we do consults, and we have found neuromuscular blockers kept in areas other than the perioperative area in the emergency department. So that's something that all hospitals should be looking at. It really should be limited availability in automated dispensing cabinets outside of those areas. Shouldn't be available. If they are going to be available at all, or any of the ADCs, we do highly recommend that they be in a rapid sequence intubation kit. And we'll talk about overrides in a minute, but even it's hard to prevent overrides from being done when you need this drug in an emergency, one of these drugs in an emergency. But if that's going to happen, again, we do recommend a rapid sequence intubation kit be available in that cabinet and not just loose vials, if at all possible. The other thing, segregate and sequester neuromuscular blockers. And that goes for the pharmacy as well as wherever the drug is stored. Again, we really push for keeping it in lidded pockets in an automated dispensing cabinet. If it's on shelving anywhere or in a refrigerator, keeping it in a box so it doesn't get mixed in with other drugs or other drugs don't get mixed in with that. In the cabinets, locked, lidded pockets. We do usually see those now when we are in hospitals. So their cabinets are no doubt safer today than they were 15, 20 years ago when we had a lot of the problems that we had. But we do still see them. And even in pharmacies, we see the neuromuscular blockers mixed in with other drugs on shelving, especially when they can be kept outside of a refrigerator. So we really think these should be stored in a segregated manner and sequestered by placing them in some kind of a container or a locked lidded pocket in an ADC. And obviously, having reversal agents, Judy mentioned sugammadex, and neostigmine is another one that's commonly used. Sugammadex, at least for rocuronium and vecuronium. They may not be available. We actually have had instances, and one of the recommendations that we've made in our newsletter articles is to always be prepared for medication or serious medication errors. This would certainly be one of them, and be prepared with reversal agents, antidotes, etc. And so certainly that would be the case here. And succinylcholine, that specifically, can induce malignant hyperthermia. And so, that is something you should have available where succinylcholine might be used, or at least the capability of rapidly accessing the necessary dantrolene in a situation like that. As far as warnings on the containers, I don't know. This is going back a while now because I've been with ISMP quite a while. But long ago, even before I came to ISMP, we had labels made up. And I know that terminology is not necessarily understandable to everyone, as Judy pointed out, but I always had labels that went onto every vial that said warning paralyzing agent. They went right across the cap of a vial. I don't think we used many ampules in those days, fortunately. But if we did, we would have probably put them in those containers too. And I mean the individual vials wherever they were kept, and that's including the OR. Fortunately, you have adequate personnel in the OR and the peri-operative areas, and you'll be able to properly handle these cases. But I do recommend that you do something special for the storage of these drugs and auxiliary warnings. We have, from time to time, written about the shrink wrap. There's some brands of that. I think more than one manufacturer has them now. And some of them have actually been placed on the vials and can literally cover the name of the drug. So you want to make sure you have an open window there so that the drug names are readily visible. And I have a picture of that there on the slide. And this would not be bad to use. The one thing that it does do, though, obviously there's a difference in between the various neuromuscular blockers, and they can have different histamine releases, different durations of activity, onset, obviously. And so you don't want to mix them up in between. And these can tend to make the different vials look similar. So just be aware of that. And maybe have a mix of warning paralyzing agent labels. And by the way, you don't need to stick with warning paralyzing agent anymore either. There are a couple of companies. I checked with one not too long ago, and you can see the label on the bottom there that not only says warning paralyzing agent, but says causes respiratory arrest and patient must be ventilated. So this might go over the locked lidded container in an automated dispensing cabinet where you're storing these drugs. It's a neat label, I think, and very visible. And you will find these if you type in on the internet, for one of the company that sells medical supplies, especially to pharmacies. And then it also has the wording, patient must be ventilated. We think that's important. And again, as Judy was saying, this does not by itself prevent errors. You need to take into account some of these other things that I'm talking about as well. You don't just want one single level of prevention strategy to help eliminate errors with neuromuscular blockers. This is just one that can add to others that you put in place. And here, as you know, we have what we call targeted medication safety best practices. And the layout on this screen is a little bit different than what I just showed you with the self-assessment, the FDA high alert self-assessment. So we're going vertically here. But if you look at segregate, sequester, and differentiate, and we do surveys of the hospitals around the country to see where they are with these targeted medication safety best practices, one of which was segregate, sequester, differentiate all neuromuscular blockers from other medications wherever they are stored in the organization. And looking at the level of compliance from none, partial, and full, You can see in February 2016, 19% said they had none. Partial was 54, and 27 fully compliant. We kept pushing, and in October 2016, we were up to 57% full when we did another survey, and in July of 2017, 70%. So this is good news, and it does speak to the fact that people are eliminating storage when they're not routinely needed. They're putting them in, a sealed box or a kit, and if it is an ADC, in a lock-lidded container, and they're placing auxiliary labels on the ADC pockets as well. So this is good news. We continue. We just did a survey in last issue of our newsletter, not the one yesterday, or not today's date, that we sent out last night, and a lot of your group purchasing organizations will be distributing that soon. But we did it 2 weeks ago. So look for that survey, and we hope you'll participate in it. And then also, we did look at the self-assessment data and neuromuscular blockers only being in the rapid sequence intubation kit and surgical kits and PACUs and anesthesia stock, and ED and critical care units where patients can be ventilated and monitored. We're up to 91% with that in the self-assessment. Now, it could be that we're getting high numbers like that with the self-assessment this past year because people are motivated to do that self-assessment in ways that people maybe that aren't motivated didn't complete the survey. So we have to take that into account. It's not a controlled study that we're doing here. And then number 5, refrigerated and non-refrigerated neuromuscular blockers are segregated from other medications or sequestered in a rapid sequence intubation kit, etc., up to 65%, so a little bit better. And then storage bins or ADC pockets or drawers containing neuromuscular blockers have that auxiliary labeling. And we're up to 63% here in the group that completed the self-assessment. So that was good news. I do want to mention that there are some labeling changes that are undergoing FDA scrutiny that actually have begun already. They communicated with all the neuromuscular blocker manufacturers to put that paralyzing agent causes respiratory arrest, and the facility must be immediately available. Facilities must be immediately available for artificial respiration. And then on the very front label panel, the principal display panel is warning paralyzing agent. The worry here, though, is that people generally tend to look at the principal display panel and they don't turn the vials around to see the other information. Hopefully they will at one time or another, and it'll serve as for educational value, but I don't know that it's going to be enough to stop someone in their tracks. And again, we are telling people to add auxiliary labeling or maybe even use that shrink wrap on the vial, so it may not be as visible as it should be. So we've been interacting with FDA and wondering if we can't get a better location for that and making it more recognizable in some way, like referring to the back label panel from the principal display panel. We'll talk about that with them soon. So anyway, just again, the labeling is just not enough. We're really glad to see FDA taking this type of action, though, and we'll see what happens with that. Also, it is in the prescribing information, and mostly the clinicians are not going to see that. So, and also, we want you to store all drugs in vials with the cap intact, obviously, so when you pick it up, you would see that, but also flat. You don't really want to, you want them to see the name of the drug and not mix up the individual paralyzing agents. So that's important to know as well. We do think if you're getting these out of an automated dispensing cabinet and you have the capability to put a warning on the ADC screen, not a bad idea to do that. And furthermore, even require the user, some systems allow this, some versions of software for the ADCs, to have the user actually enter the reason that they're using it. And that might be enough to signal, well, this isn't for a paralyzing agent or a neuromuscular blocker, maybe I have the wrong drug in hand. So, if that's available to you, we did talk to the ADC vendors, and I'll get to that in a minute. But it's highly recommended that this capability be there. And then requiring a witness. Just these drugs are one of those drugs that, if you're removing it from an ADC and knowing how many problems we've had, especially this most recent one that we wrote about earlier this year, we really think that the cabinet should be set up, at least for certain drugs and drug categories, that if you're removing them on override, especially on override, or maybe only on override, you really need to have a second individual independently check and then identify themselves. And we're even recommending biometrics. So we have talked to both Omnicell and BD Pyxis about that. It was a couple of months ago, and we are going to follow up with them to make sure they're following through. They did initially tell us they would be willing to do that. They also told us that, I probably have this on another slide, they would be willing to look into a certain number of letter characters to pull up a drug like vecuronium, maybe 5 or 6, for that to even appear on the screen rather than just VE, which we've now had 3 instances of mix-ups with those drugs reported, only one of which, thankfully, was, well, not thankfully, obviously, was a serious error. The other 2 weren't actually given. So requiring that second individual to verify the patient and the medication and the purpose, really important. So these are the vendor improvements that we asked for. I think I just went over these, so I'm not going to spend a lot of time with this, and I want to get to questions. But increasing the number of letter characters required for certain drugs, including neuromuscular blockers, witness upon removal, and then allowing simultaneous generic brand name searches. I forgot to mention that. In this incident that we had earlier this year, the cabinet was set to only use generic names. So if midazolam was typed in, it would have been fine. But the nurse typed in VE for Versed, and it wasn't set up to search by drug name. We think simultaneously both names should be visible. And so we asked the cabinet manufacturers to look into that as well. And you know what? I hope, most of you are using these already. I hope you'll get behind these as well. And let's put some pressure on the vendors to accomplish this. Ask it of your salesman. Ask them to follow through with management. I have to tell you, we had a very good experience dealing with these individual companies, and they really care. And so we hope that it comes to that, but any help you can give it would be very much appreciated. I think, 5 years down the road, all of us are going to be using cabinets with different versions of software and, newer models, at least we hope so. We can avoid these types of errors from cabinets. As far as syringe labeling, we do recommend the labeling that has the anesthesia color code. So if you're using an outsourcer, and many of you are, and I have some data on that that I'll show you in just a minute, that would be great. But we do think the color coding is important. And most of the outsourcers do a pretty good job with that. And even to help them, my biggest worry with the neuromuscular blockers is the anesthesia red color is used for all of them. And so unless they take other steps, like using geometric forms, using reverse print while they still maintain the color, putting an extra label on the plunger of the syringe, and so on, as many of you have seen, if your outsourcer isn't doing that, you should change outsourcers, because they're going to mix up the neuromuscular blockers in between the drugs in that category. So to the greatest extent possible, we do recommend, I know it's more money, we do recommend providing anesthesia with labeled pre-filled syringes, and the outsourcers will do that. What some other hospitals are doing, they do have label printers with a barcode on it. Unfortunately, not many hospitals in the OR use barcoding. That's starting to change. The barcoding generally doesn't work in an interactive way with what's been ordered for the patient at this point. So it really, you do rely on a printed label with a barcode and then matching that with the drug vial to make sure you have the right drug vial in hand, which is a help. But obviously it's not the same as what you would see on the nursing unit when somebody actually orders the drug and Pharmacy dispenses based on the barcode, a label printout, and nursing administers it based on a label printout. You don't have that in most ORs. Anyway, labeling all syringes is most important. So here's some data. Anesthesia provided with and use labeled pre-filled syringes of neuromuscular blocking agents, 16% fully compliant. So we got a lot of work to do there. And then syringes of neuromuscular blocking agents prepared by anesthesia staff are labeled with a name and concentration. Good news, 66% said they do that. I mentioned the barcoding already. We are hoping against hope that more anesthesiology folks will adopt these for safety, that the drugs used in the OR in general will allow, and many of these can be ordered. You have an order set, for example, you know what's going to be given to that patient for that condition. So the circulating nurse knows, the OR nurse or technician knows. The circulating nurse would be able to use barcoding. The anesthesiologist would be able to use barcoding for neuromuscular blockers. And then post neuromuscular blocker administration, Judy talked about this a little bit. Make sure when a patient is extubated, they still have that IV container with neuromuscular blocker. You take that off right away. You make sure somebody's doing that, and that's in the protocol. And then also you flush the line before that patient is extubated. That's critically important. We do have errors, as Judy mentioned, where that hasn't been done, and then the patient gets bolused with whatever else is hung or pushed in through a Y site. And unfortunately, we've had some adverse reactions from that. So removing all source containers and then destroying any vials that are left over that haven't been fully used. And then just a couple more slides. Staff education. Make sure they understand what neuromuscular blockers are and what they do. And not every nurse, depending on where they are, they might get called to another unit. You know how that happens all the time. In fact, this particular nurse was called to another unit. Well, that wasn't a factor, but was called to the radiology department, which she had not really worked with and didn't know the protocol there. Generic and brand names, important for these drugs. Special safeguards in place for the neuromuscular blockers, and then competency verification where these drugs are used and for those individuals. I mentioned the newsletter article, and I also mentioned the high alert drug self-assessment, which is on our website. Now, Jordan, I am having trouble reading the questions. I've tried to get the more information, and I can't read it. Can you read me a couple of the questions, please, or Judy?
Yes, I don't think we'll be able to answer all the questions, but there are several questions about virtual kits and whether ISMP recommends the use of a virtual rapid sequence intubation kit in an automated dispensing cabinet or a separate type of rapid sequence intubation kit. So the question's asked several different ways, but just on the topic of virtual kits, I thought maybe we could answer that question. So from our perspective, we're not opposed to the virtual kits, but here's the downside of them. The drugs are still available in an automated dispensing cabinet, although you're having people go to the automated dispensing cabinet to get the pieces that they need for the rapid sequence intubation kit. They're still in the automated dispensing cabinet and could be available to be picked in error. So what we'd rather see is and what we think might be safer as a general statement is that we'd rather see the neuromuscular blockers outside of an automated dispensing cabinet, unless it's part of the refrigerated part, in a sequestered rapid sequence intubation kit that can be quickly grabbed. Some of the safeguards that we would like in place for a neuromuscular blocker might not be possible when you need to quickly grab that rapid sequence intubation kit. And having it available in automated dispensing cabinet leaves it open to possible misselection in some way. So that's our stance on virtual kits, we're not opposed to them, and everybody sets them up a little bit differently in their automated dispensing cabinets, and that would be a big consideration. But as a general rule, just keep in mind that they're still accessible in an automated dispensing cabinet, whereas they might be more sequestered and secure in a rapid sequence intubation kit, that if it's kept in an automated dispensing cabinet is kept in a kit in the refrigerator rather than a virtual kit. I think there are. Go ahead.
I was just going to say, a couple of you asked about downloading the PDF. You had some trouble with that. If you can't get it, and I was able to get it just by double clicking, but a couple of you said you weren't able to get it, just email me, mcohen@ismp.org, and I'll email it to you. And I'm sorry that happened to you.
I will also send it out with the follow-up email.
Oh, okay. Thank you, Jordan. And then there's a question here regarding Versed and Vecuronium. To what extent do staff know the names of these drugs? Could they think Vecuronium is the generic name for Versed? And we don't know the whole story yet in that case. But yes, absolutely that can happen. And I did mention that at the very end on one of my slides. It would be a great idea to have, if you're storing neuromuscular blockers in a particular area, especially outside the OR or the emergency department where they're used very, all the time, commonly. I would definitely have so the neuromuscular blockers that you have and the other agents and make sure that people were aware of them. But it is definitely a possibility. And then regarding,
I think the other thing, Mike, is that, and you might have mentioned it already, is that we've asked the vendors to make sure that any type of a search is by either brand or generic and not one or the other, because we don't know for sure that the end user is going to know both the brand and the generic name.
Yes, I did mention that. We had spoken to the vendors, and we're going to, ask them we're going to follow up with them, but I was hoping that the people that are listening on this call that have ADCs, no matter which one you use, will follow through and ask your vendors to supply things like that too. So you'll get a copy of the slides. So the next question I had, it is a basic problem that many people simply don't know the names of medication. That's kind of similar, so I'm going to bypass that. Are interruptions during preparation or administration, either in pharmacy or with nurses on the unit, being a contributing factor to these errors? Boy, we've written about interruptions. Maybe we should do it again, but obviously breaking your train of thought absolutely can have an effect in increasing the risk of error. You think you're taking one action, and unfortunately you easily can take another. And that's exactly how something like ordering it on the wrong patient can happen. And I explained one of those situations. Judy, you want to chime in too?
Yeah, there's a whole host of environmental conditions that are not specific to neuromuscular blocker errors that we didn't cover. So what we tried to cover today are those things that are very specific to neuromuscular blockers. Interruptions and distractions are going to be at the root of many errors with different drugs, especially when they have a complex preparation and administration process. So we weren't unable to cover all of those types of conditions that might also contribute to errors with neuromuscular blockers because they're not specific to neuromuscular blockers.
Someone's asking, can the webinar be accessed for other staff to view at a later date? Yes, we recorded this session, and we'll keep it on our website, and you'll be able to get the slides as well. Since succinylcholine vials need to be refrigerated to extend the beyond use date, yes, we know that. Didn't used to be that way, but the manufacturer changed the labeling. What are the best practices on how to store RSI kits? Yeah, a good question. Virtual DC, purchase succinylcholine syringes from pharmacy repackagers. That's probably your best bet because they can extend the date. So that's not a bad idea to do it that way. Judy, you have anything to add there?
No, I think they asked about the virtual kits also, and just a word of caution that remember your virtual items are still available in the ADC.
Right. Oh, for the FDA.
They're not quite.
I'm sorry. Want to ask a question, Judy? Go ahead.
No, I was just going to say they're not quite sequestered enough
okay.
sometimes in the virtual kits. That's all.
Okay. We'll do this last question. And Jordan, how do we get the rest of these questions answered?
I can download them for you.
Okay, that'll be good. For the FDA and for vendors, is it possible to request that manufacturers cover vials with shrink wrap or auxiliary tadpole labels? I'm afraid not. FDA doesn't have the authority to require something like that. And it would be setting up a new manufacturing line, and we'd probably get a lot of complaints like that. I doubt that could be handled. I certainly ask my colleagues, but I don't think they have the authority to require something like that. They might have the ability and certainly could twist arms to include the tadpole label in the packaging or some other label in the packaging. That might be a possibility, but I don't think they can make them put shrink wrap over the label, because then would eliminate some of the labeling that is required on the container. So I don't see that being done. Judy, anything else, or else I think we better end and thank everybody for attending, and we'll make sure that this is posted, and I'll try to get to the rest of these questions. We've got quite a few of them. We had a lot of people attending. We are happy to do these free webinars every once in a while, and we hope you'll join us again. Thank you very much.